Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Fathom Pharmaceuticals.
Hello, I'm Dr. Reina Yadlapati. I'm a professor in the Division of Gastroenterology and medical director at the Center for Esophageal Diseases at UC San Diego. Welcome to this Medscape program titled Managing Erosive Esophagitis When PPIs Are Insufficient. I'm very pleased to be joined today by my expert colleagues, Dr. Amit Patel, who is a professor of medicine in the Division of Gastroenterology at Duke University School of Medicine in Durham, North Carolina, and Dr. Leila Kia, who is an associate professor of medicine and fellowship program director at the Feinberg School of Medicine at Northwestern. Welcome, Amit and Leila. So today we're going to be discussing the management of erosive esophagitis, and more specifically, how we evaluate patients who are not responding adequately on PPI therapy. And where do we go from there? So let's start by introducing a patient case. So I'm going to tell you a little bit about Peter. Peter's a 45-year-old man with daily heartburn and regurgitation. About 8 weeks ago, he was started on omeprazole 20 milligrams daily, but now he's presenting with continued symptoms. So he undergoes an upper GI endoscopy while he's still on the omeprazole. And what that reveals is erosions. And these are consistent with Los Angeles grade D erosive esophagitis. Now, typically, when we see erosive esophagitis, we classify it according to the Los Angeles criteria, which spans from A to D, where A is having one or more mucosal breaks that are short in length, all the way up to D, which is very severe esophagitis, where there are mucosal breaks that are encompassing more than 75% of the circumference. So Peter has LAD esophagitis. Now, upon talking to him more, Peter states that he's been taking his PPI inconsistently. Sometimes he'll take it before meals, sometimes after, oftentimes at bedtime. So Amit, let's start with you. I'm sure this sounds familiar. What are your impressions of this patient? Is this someone who you would say has PPI refractory erosive GERD? And do you think that Peter had an adequate trial of PPI?
Thanks, Reina. To address these great questions, let's start by discussing how we approach patients like Peter who present to our clinic with typical GERD symptoms of heartburn and or regurgitation. This figure here is adapted from your AGA clinical practice update on the personalized evaluation management of GERD. Up top, two considerations to keep in mind when we see these patients. First, if patients have alarm or red flag symptoms, so things like dysphagia, GI bleeding, weight loss, persistent vomiting, they deserve further evaluation, often with upper endoscopy. And second, if patients have chest pain, they deserve a cardiac evaluation. With that said, otherwise, patients with typical GERD symptoms can be offered an empiric trial of PPI with evaluation of symptom response. For those patients whose symptoms resolve with this, that's great. We can then wean to the lowest effective dose and or consider on-demand therapy for them. On the other hand, though, for patients whose symptoms do not adequately respond, we can evaluate their adherence and consider increasing the PPI dose. While Peter, apart from us already knowing his EGD findings, would otherwise fall into this latter group, he's not taking his PPI consistently, nor taking it before his first meal of the day, both of which we would want our patients to do in this setting with a PPI trial. So no, we would not necessarily consider Peter's to represent an adequate trial of PPI, particularly given that we know he has LA grade D erosive esophagitis on his EGD. This represents confirmatory evidence for a GERD diagnosis. Per the Lyon consensus, LA grades BCD erosive esophagitis, biopsy-proven Barrett's esophagus, or peptic stricturing on EGD all represent confirmatory evidence for an objective diagnosis of GERD. But moving on, Reina, you asked about PPI refractory disease. Let's talk about what that means. The term refractory in this setting typically implies despite patients adhering with optimized or double dose PPI therapy for at least 8 weeks. So, within that context, when we say refractory symptoms, that should refer to persisting symptoms that may or may not be related to GERD. On the other hand, refractory GERD symptoms are persisting symptoms in the setting of proven objective GERD, regardless of their relationship to ongoing reflux. And finally, refractory GERD means that we have objective evidence of GERD despite adequate medical management, as with optimized PPI therapy. While Peter does have objective evidence of GERD based on the LA grade D erosive esophagitis on his EGD, he is not taking consistent nor optimized PPI. So I would not label him refractory at this point yet.
That's really helpful, Amit. Thank you. So then, Layla, it's pretty obvious that Peter's not taking his omeprazole correctly. First of all, how common is a problem of PPI non-adherence? And then how do you counsel your patients about this?
Thank you, Raina. Yes, I think it's pretty clear that Peter is not taking his PPI appropriately. And this could certainly be one of the explanations for his ongoing symptoms. And in fact, we know that anywhere between 30 to 40% of patients with GERD actually report ongoing symptoms. Now, true refractory GERD, the way that Amit presented that, meaning that we have ongoing evidence of reflux in the context of proven GERD in somebody who has persistent symptoms, is actually quite uncommon. Only about 10% of people have that. And we find that a lot of these non-responders become responders when we address some lifestyle or compliance issues. We know that if anywhere between 40 to 60% of patients are actually taking their PPIs incorrectly, that's a very large number. So if we take the time to really get a good history and understand why they're not taking their PPIs appropriately, just by sitting down and taking a couple minutes with them and counseling them on how to take their PPIs appropriately, they can actually go from being PPI non-responders to PPI responders. Now, one of the questions that sort of comes up is why do patients have such a difficult time taking their PPI appropriately? And one of the issues has to do around take the timing of the PPI. So certainly it can be challenging for patients to remember to take their PPIs 30 to 60 minutes before breakfast. It can be challenging to time it in relation to other medications that they may have to take fasting, such as thyroid medications. They may not have been counseled on how to take these medications appropriately. So there are several different factors that can contribute to this sort of non-adherence or not compliance to our recommendations or to the appropriate dosing. As far as, how are patients actually taking their medications? Well, when we look at patients that are taking PPIs suboptimally and break it down, we actually find that it's really all over the map. Some patients are taking their PPIs more than 60 minutes before a meal. Some patients are taking their PPIs after a meal. Some patients are taking their PPIs at bedtime. And some patients are actually just taking their PPIs as needed. And we all encounter those patients who are sort of afraid of the long-term adverse events associated with PPIs and who prefer to take on-demand PPI therapy. But we know that based on the pharmacology of PPIs, it's just not going to be as effective to take the medication on as needed basis. So it's really important for us to take the time to counsel patients on how to take their PPIs appropriately. And what I tell patients is, you got to take it 30 to 60 minutes before breakfast. And it's actually also important to eat after you take your PPI. So if you take your PPI but don't eat for another 3 to 4 hours, that's actually not the right way to take the PPI either. For those who require twice a day dosing, it's best to take it before dinner, 30 minutes before dinner, rather than taking bedtime dosing, which is not going to be as effective. And as I mentioned previously, it's very important to emphasize daily adherence rather than taking the medication as needed. And then finally, I think it's always a good opportunity to highlight and emphasize the importance of lifestyle factors that can also contribute to symptoms, to ongoing symptoms, things like weight loss, avoiding late meals, lying down after eating, and elevating the head of the bed, all of which may help to minimize symptoms, in particular nighttime symptoms.
I love that, Layla. Those are such great key pearls. And in particular, what you said about just spending a couple minutes with a patient can convert them from a PPI non-responder to a responder. That's really powerful. Well, Amit, what if poor adherence is just one of the several possible causes that Peter's not responding to PPIs? What are some of the other possibilities, and how do you approach this in clinic?
Absolutely. Beyond patients not being adherent with and or taking PPIs incorrectly, as Layla discussed. And to be honest, that should be number one, two, and three. After that, it can be helpful for us to think about patients with PPI non-response in a couple of broader ways. The first would be there's a group of patients for whom acid reflux continues to occur despite taking PPI in an optimized way. We'll discuss how PPIs can vary in potency and genetic differences in CYP2C19 metabolism can affect PPI response to varying degrees. But the second consideration that's important to keep in mind are a lot of these patients may have an alternate diagnosis causing or contributing to their symptoms. And these could include things like functional heartburn or reflux hypersensitivity, where we have physiologic or normal esophageal acid exposure with positive reflux symptom association. But other non-GERD disorders can include things like esophageal motor disorders like achalasia, mucosal diseases like eosinophilic esophagitis or EOE, behavioral disorders like rumination or supragastric belching, or gastroparesis. So when these are present, and clinical science point to these, identifying these disorders in PPI non-response is crucial to help guide the personalized management of these patients. So how can we approach our patients with PPI non-response in the clinic? If the PPIs are optimized, like we talked about, we could confirm a GERD diagnosis objectively and or investigate alternate diagnoses. For Peter, in this case, we know that he had LA grade D erosive esophagitis on his EGD, representing objective evidence of GERD. However, his PPI therapy was not optimized. So for Peter, we want to start by optimizing his PPI therapy. As Layla highlighted, it's really important to educate and counsel on the pathophysiology of GERD, how PPIs work, and this will help maximize patients' compliance or adherence with and correct timing of PPI. This education is also helpful for maximizing adherence with other treatment recommendations, like the lifestyle or behavioral modifications that Layla mentioned. We talked about how for PPI dose timing, really trying to get it 30 to 60 minutes before the first meal of the day, and for double dose before that dinner meal. The Oscar trial on optimizing PPI dose timing reinforced how even brief patient education on proper PPI administration can help reduce GERD symptom burden. Regarding increasing the PPI dose to twice daily, that split twice daily PPI therapy is superior to once daily double dose PPI in maintaining the gastric pH above 4 for higher proportions of the day. But because there is variation in intergastric pH control between PPIs, we can consider switching therapy in some patients. This could mean switching to a more potent PPI and or one with less reliance on metabolism through that CYP2C19 pathway. These might be PPIs like rabeprazole or esomeprazole, or considering an alternate acid suppressive agent. So when we think about PPI potencies, although PPIs are generally effective for healing reflux esophagitis when taken appropriately, there is some relative variation in that acid suppression potency. So if we standardize the potencies of PPIs to omeprazole, the relative potencies vary, and this can range from pantoprazole with a relative potency of 0.23 to rabeprazole with a relative potency of 1.8. With that said, even twice daily dosing of the least potent PPI, like pantoprazole, would equal or exceed the effectiveness of taking a once daily higher dose of a more potent PPI in terms of that proportion of time with the intergastric pH above 4.
And thank you. I think it's really important to remember that not all PPIs are created the same, just like you outlined. And so very important to think about that and discuss that with our patients when we're also counseling them on optimizing how they can take their PPI. Now, PPIs have a lot of benefits, but of course, like all medications, there are some drawbacks in them as a class. And we've talked about how, first of all, they've been on the market for many years and decades, and we know that they're very effective at healing conditions such as esophagitis. You've just talked about how they have a high relative potency, especially with regards to some of the PPIs in the class, and they have a long persistence of action, especially if we dose it BID. But there are important limitations. First of all, like our patient, his symptoms are still persisting despite being on PPI, and we encounter this very frequently. And then perhaps one of the biggest issues is that there's this potential for long-term risks, and patients come in very commonly concerned about taking PPIs long-term. So, Layla, how do you approach this in with patients in terms of their concerns about PPI safety? What are really some of the true risks versus maybe just some myths?
Thanks, Raina. Yep, this is a very common question that we all get in our clinics several times a day. So, patients are concerned, primary care doctors are concerned, and many of us in the community are certainly concerned. And the reason for that is that many of these concerns come from data that came from these large observational studies that showed potential associations between several different potential adverse events and long-term PPI use. And there's sort of a laundry list of different potential adverse events, such as dementia, osteoporosis, fractures, CKD, heart disease, cancer, you name it. But what it comes down to is that these studies were not designed to actually prove causality. They simply identified associations. So we can't really draw any meaningful conclusions from those particular studies. Now, having said that, there have been some well-designed prospective studies that have aimed at controlling for many of the variables that were not controlled in those previous studies. And many of those adverse events that I just listed have not been shown to actually result from a long-term PPI use, with the exception of enteric infections. And we do know that long-term PPI use does likely increase the risk of developing certain types of enteric infections, including sort of a rare, but certainly potentially severe infection, C. diff, or bacterial gastroenteritis. Now, we also know that PPIs are associated with microscopic colitis, or can be associated with microscopic colitis, and the development of acute interstitial nephritis, which is an idiosyncratic reaction, can occur with the first dose, or it can occur after the 1000th dose. So these are things that I will counsel patients about when we discuss safety of PPIs. Now, I always like to take a step back and tell patients, listen, we first have to make sure that you're taking the PPI for the right reason. Every medication has potential drawbacks and side effects, and we want to make sure that you're on a PPI because you need to be on a PPI. And that takes us back to establishing the diagnosis of GERD, either through evidence of erosive damage, Barrett's, peptic strictures, adenocarcinoma, or endoscopy, or through a pH study that is positive off acid suppressive therapy. And then once we have that diagnosis, actually trying to de-escalate and find the lowest effective dose that can manage a patient's symptoms. I think that's also very important. Oftentimes patients come in on very high doses of PPI, and I think it's our job to try to find, again, the lowest effective dose that can manage their symptoms.
That's great, Layla. Thank you. I think another great key pearl summary that you just had. And I found in clinic that taking that couple minutes to really review the data and provide that reassurance really goes a long way for a lot of patients. So thanks for reviewing that. So if we come back to our case, Peter's a 45-year-old man who presented with persistent GERD symptoms, and we found that he had Los Angeles grade D erosive esophagitis when he was on omeprazole. So he was then switched from omeprazole to now rabeprazole, 20 milligrams BID, and was also counseled on how to take his PPI appropriately. So he is now on optimized PPI from what we've learned today. And he comes back 4 weeks later and has had some improvement, but he's still having symptoms near daily. So the question becomes, what would you do next, Layla?
Yeah, so that's a great question, Reena. And, in this patient who had LAD esophagitis, despite PPI therapy, whether or not he had room to be optimized on his PPI, he warrants a repeat evaluation through an endoscopy to assess for hopefully healing of that esophagitis. So we've made a couple of changes here. We've changed his PPI to a more potent PPI that's metabolized through a different mechanism, so gets around the potential for a rapid metabolizer. And we've also taken the time to counsel this patient on compliance and adherence. So it's really important to repeat the endoscopy, ensure that or assess for healing of esophagitis, and then also to screen for or evaluate for potential Barrett's, which may be underlying the finding of esophagitis.
Yes, that's very important. So that's exactly what we do with Peter. He gets an upper GI endoscopy, and this time he is on his robeprazole, 20 milligrams BID, so optimized PPI. And on endoscopy, we see that he now has Los Angeles grade B erosive esophagitis. So remember, when he first had his endoscopy, he had Los Angeles D, and that is going to be the most severe form of erosive esophagitis. Now he has Los Angeles B, where there are one or more mucosal breaks that are at least 5 millimeters long, but not extending between the tops of two mucosal folds. And as Amit mentioned, according to Lyon consensus, Los Angeles B, C, or D are confirmatory for GERD, whereas Los Angeles grade A is not necessarily conclusive for GERD. So now Peter has ongoing Los Angeles grade B esophagitis this time around on his endoscopy. So then, Amit, this comes back to you. Our patient still having symptoms, still has some form of erosive esophagitis despite this optimization. What do you do now?
Great. So this algorithm illustrates how we can approach these patients who have refractory symptoms despite optimized twice-daily PPI therapy in the setting of proven GERD. Like Peter, as you pointed out, who had LA grade D erosive esophagitis on his original and first EGD. As we discussed, repeating EGD for the healing of erosive esophagitis on optimized PPI therapy was appropriate for the reasons that Layla mentioned. Unlike Peter's EGD, though, if we had a patient whose EGD in this setting was unrevealing, so without erosive esophagitis, without eosinophilic esophagitis, we could consider esophageal physiologic diagnostic testing, as Layla alluded to. So this might include esophageal high-resolution manometry to exclude motor disorders such as achalasia, and pH impedance monitoring on PPI to help assess the etiology of these persisting symptoms. These tests can also help identify behavioral contributions that we mentioned, things like rumination or supragastric belching. Now, if there is evidence for ongoing or inadequately controlled GERD despite optimized PPI therapy, like the erosive esophagitis on EGD in Peter's case with that second EGD, or there are combinations of abnormal metrics, so things like esophageal acid exposure time, reflux episodes, baseline impedance on pH impedance testing performed on PPI, that represents refractory GERD. So that's kind of the bucket that Peter is in after the definitions we've discussed before. For these patients, we want to take a precision approach to escalating their anti-reflux therapy. And that means taking into account factors like their symptoms, reflux patterns or diagnostic findings, patient preferences, the anti-reflux barrier integrity, obesity, and psychological considerations. Layla discussed some of the lifestyle and behavioral interventions that we can discuss and consider for our patients like this. And those could include things like weight loss, dietary modifications, sleep strategies, and diaphragmatic breathing. Beyond that, we can also consider personalized adjunctive pharmacologic therapies. So these adjunctive medications can include nighttime H2 receptor antagonists for refractory nocturnal symptoms, alginate antacid preparations for patients who have postprandial and or nighttime symptoms, or baclofen in patients that have regurgitation or belch predominant symptoms, particularly with the positive reflux symptom association. Prokinetics, though, should typically be reserved for those patients with refractory GERD who have evidence of gastroparesis. PCABs, or potassium competitive acid blockers, are a newer class of medications that can suppress gastric acid more potently than PPIs. And then finally, we have endoscopic and surgical anti-reflux interventions. So these are things like transoral incisionless fundoplication, tailored laparoscopic fundoplication, magnetic sphincter augmentation, or Roux-en-Y gastric bypass. And these are all effective therapies that can be considered in selected patients.
Thanks, Amit. It's really great to know and for patients to know that there are many different treatment options beyond PPIs and that it can be personalized specifically for them. And like you mentioned, we now have PCABs, specifically vonoprazan, which is a first-in-class potassium competitive acid blocker that is FDA approved in the United States to treat both erosive and non-erosive GERD. So how do the PCABs differ from PPIs, and which patients would benefit most from trying a PCAB?
Right, so PCABs bind reversibly to the proton pumps of the gastric parietal cell. So they block potassium ion access to suppress gastric acid secretion. Unlike PPIs, PCABs are acid stable, and therefore they don't need enteric coating or to be dosed before meals, as we discussed for PPIs. Further, PCABs are active drugs, not prodrugs like PPIs, meaning they have a more rapid onset of action. So they reach maximal acid suppression sooner than PPIs. PCABs also have longer half-lives than PPIs, so this facilitates more prolonged gastric acid inhibition. And finally, PCABs are not primarily metabolized via that CYP2C19 pathway, and thus they're less impacted by genetic polymorphisms. So, given these pharmacologic features of PCABs, while they are approved for healing all grades of erosive esophagitis, they may be particularly useful for us in certain clinical settings or helpful for our patients. Clearly, for more severe grades of esophagitis, persisting erosive esophagitis or refractory GERD, despite PPI therapy, such as in Peter's case. Patients that have harder to treat reflux. So these might include patients that have larger hiatus hernias, those with achalasia who've undergone POEM, or those with profound esophageal hypomotility. They can benefit from PCABs. PCABs can be quite helpful in situations where rapid healing of esophagitis can provide clinical benefit. Such as cases where there's associated bleeding with that esophagitis or following endotherapy of Barrett's esophagus. Other settings that PCABs could be useful include those patients who might not be great candidates for some of those more invasive anti-reflux interventions we discussed, or those who might have difficulty timing PPI dosing due to their work schedules.
That's great. So, Layla, having heard all this about PCABs, is switching to a PCAB a viable option for Peter? Or is there something else you would try before that or in addition to that? And what options are there?
Yeah, I think Amit did a really good job of summarizing some of the sort of indications or the rationale for switching to a PCAB, and certainly Peter does fit into that criteria. He has ongoing erosive disease despite taking twice daily rabeprazole and adhering to lifestyle changes and being compliant with the medication. So I would certainly consider switching him to a PCAB at this point. At the same time, I would also consider additional diagnostic testing to try to get to the bottom of why he has ongoing erosive disease. And so, as Amit mentioned, high resolution manometry and 24-hour pH impedance on PPI therapy or PCAB would be reasonable depending on which, if we wanted to try switching to a PCAB first and then scoping him again after an adequate trial to assess for healing versus proceeding with further phenotyping off on the PPI therapy. And, I think it's important to do that because there may be other factors that are contributing to some of his ongoing symptoms, perhaps not so much to the ongoing erosive disease, but to some extent, maybe contributing certainly to ongoing symptoms. So certainly, stress management, I think, is important. There may be some behavioral modifications, or we may rely on the use of some neuromodulators to help address some issues relating to hypersensitivity or hypervigilance if patients do have ongoing symptoms despite being optimized on PPI therapy. And then certainly he may have developed some health anxiety relating to his symptoms. So considering stress management or consulting with a health psychologist may also be useful. We've already touched on some of the lifestyle modifications that are very important as well. Certainly weight loss. We know that even modest weight loss can be very effective in helping to manage symptoms. Meal timing can be critical. We probably need to tease out a little bit more what's going on with Peter's diet and lifestyle. Is he eating a big meal right before he goes to bed? And addressing some of those other factors may help us get some better control of his symptoms. And then we mentioned already some of the other lifestyle modifications, such as elevating the head of the bed, laying on the left side, and again, avoiding late meals. All of these sort of contribute to a multifaceted approach to helping to manage Peter's symptoms.
Amazing. Well, Dr. Patel, Dr. Kia, this has been such a great discussion. Thank you so much for your time and expertise. Let's wrap this up with a few key takeaways. So, remember, many patients come in with ongoing symptoms. This doesn't always mean that they have refractory GERD. Oftentimes, they may not be taking their PPI adequately or accurately. So, remember to make sure that they have a correct indication for their PPI, that they're adhering to it in terms of the way they're taking it, and they're on an optimized dose. Also, we've covered the whole breadth of different holistic and personalized approaches for our patients that go far beyond PPI therapy or anti-secretory therapy. So remember to take the time to think through that. But if your patient has persistent refractory GERD, especially erosive esophagitis, escalating them to a double dose PPI or a potassium competitive acid blocker would be the next step in management. And we now do have new therapies such as PCABs that are available and are expanding options for PPI refractory erosive GERD. And so with that, again, I want to thank you both, Amit and Layla, for joining me today for this great discussion. And I want to thank everyone else for watching. Please take some time to answer the questions that follow this and complete the evaluation. Have a great day.